When we talk about renal cysts, we also have to talk about renal cancer, because any cyst could actually be cancer. We're going to begin this discussion with talking about simple versus complex cysts and when you should biopsy a lesion versus when you should simply resect it. And we'll finish off with the genetic disorders, autosomal dominant and autosomal recessive polycystic kidney disease. Let's talk about a simple cyst first. And a simple cyst is something that you can just leave alone. That's a kidney, and that's the simple cyst. Simple cysts are meaningless. The patient will be completely asymptomatic, and they're only found because you did another test for another reason. The person who gets a CT of the abdomen or an ultrasound of the kidney for another reason happens to find a cyst. That is, they are incidental. But in order to be simple, they must be small, have no loculations, and no septations. It is essentially a balloon filled with fluid. You leave them alone, they don't cause any problems, which means that you need to do nothing with their diagnosis and nothing with their management. And you will realize that as people get older, the incidence of simple cysts increase. If you compare that to a complex cyst, complex cysts are going to be larger. They're going to have septations, loculations, and you might find something growing in here. They've got different echogenicities. It's not homogeneous, it's a heterogeneous structure that's large. A complex cyst. Now, complex cysts can be a lot of things. They can be cancer, they can be an abscess, they can be a lot of things, but your job is to decide, is this likely to be cancer? The way this is going to come up on the test is as a flank mass. In real life, the complex cysts are found like simple cysts. You do a test for another reason, you end up finding it. But this flank mass is large and full of fluid, so it is possible that you get an infection. And this presents like pyelo. These things can hurt, so you might have flank pain. And these things can rupture and bleed, which leads to hematuria. So you might have a flank mass, flank pain, and hematuria, which, as we'll learn, is the presentation for renal cell carcinoma. You might present with flank pain and hematuria, which is the presentation for kidney stone. This can be very similar to a lot of other things, like pyelonephritis. So chances are the diagnostic workup is going to involve a urinalysis and then eventually a CT scan. If you can, get the CT scan. If you can't, because you're pregnant, use the ultrasound. And in order to make the diagnosis, you're going to do a biopsy. The treatment is going to be disease specific. But in general, these things need to come out, so resection. But if this were an abscess, you drain the abscess and give antibiotics. If it's a malignancy, you resect and stage chemoradiation, etc. But the thing that is renal cell carcinoma presents similarly, but with one big difference. The person with renal cell carcinoma is going to present very similarly to a complex cyst. And what you should learn as the classic triad, classic because that's what's taught, but only 30% actually have it, is going to be flank pain, flank mass, and hematuria. You are going to do a CT scan, if you can, or an ultrasound if you can't. But you are not going to biopsy the thing that you think is renal cell carcinoma. You are actually going to do a resection. And this is done either as a partial or a radical nephrectomy. And this is the big difference. No biopsy. Don't put a needle in it because it'll cause a hematoma and there's a theoretical risk of seeding the peritoneum. The nephrectomy acts as the biopsy. The thing that comes out is big, angry, and looks like cancer. The thing that gets biopsied is smaller, not so big, and not clearly malignancy. You will not make that decision. The CT scan will make it for you. But because it's a cancer, there may be paraneoplastic syndromes that accompany this. Because it is a cancer, you may see a low hemoglobin. That is, the cancer steals the blood. But because renal cell carcinoma is of the kidney and the kidney makes EPO, you can have an EPO-producing tumor which actually causes a polycythemia. And renal cell carcinoma spreads hematogenously. So you might find a DVT or a piece of the tumor in the renal vein or in the IVC. So when it comes to cysts, you have to ask yourself, is this renal cell carcinoma? If it's really tiny, no loculations, no septations, leave it alone. If it's a little bit bigger and has multiple pockets, put a needle in it, then cut it out. If it's very clearly malignancy or you have a paraneoplastic syndrome, don't put a needle in it, just cut it out. Now let's move on to the genetic disorders. Autosomal dominant polycystic kidney disease and autosomal recessive polycystic kidney disease. All right, let's talk about autosomal recessive first because it's easier. And doing adult medicine, you will never see these. Autosomal recessive polycystic kidney disease occurs in newborns. And as the name implies, it is autosomal recessive. The patients present anuric and complete renal failure day 1. You may have had a clue that this was happening if someone had oligohydramnios. There's no urinary output from baby, and so no amniotic fluid. There'll be palpable flank masses. This occurs bilaterally. The diagnosis is made first with an ultrasound. Because it's a baby, you're not going to be using a CT scan, and then a biopsy. Because they're so young, you're not worried about peritoneal spread, but you need to make sure that this isn't another malignancy that infants get. And the treatment is simply supportive. Transplant could be curative, but because these patients are anuric, they're likely to die. And since they're so small, being a neonate, they're likely not large enough to accept a kidney. If you do the biopsy, what you'll see is radially oriented cysts, which is going to be very different than autosomal dominant polycystic kidney disease. This disease you won't see very much of, 1, because it's autosomal recessive, and 2, because the kids are usually dead by the time they see adult medicine. Instead, you're going to see a lot of autosomal dominant polycystic kidney disease. The path here is that it occurs in adults and is autosomal dominant. The patient is going to present generally completely asymptomatic, then gets hypertension, then gets end-stage renal disease. And this is responsible for 5 to 10% of end-stage renal disease. But it is possible that these cysts are palpated. That is, there's a flank mass. These cysts can get infected and present as pyelo. These cysts can bleed, presenting as hematuria. But here's the thing. They're born with essentially normal kidneys. And as they age, they get more and more of them. And they begin to get bigger and more of them. And eventually these cysts replace the kidney parenchyma. So they'll go from normal kidney function progressing through life with worsening creatinine. The diagnosis is made with CT scan or ultrasound, and then a biopsy. The treatment is to prevent the progression of renal disease, just as we talked about in chronic kidney disease. It is essentially supportive. Keep the blood pressure low, treat proteinuria with ACE inhibitors and ARBs, and eventually they go on dialysis. They can be transplanted. But more than just the kidney is affected in this disease. They can have cysts in the pancreas and the liver, leading to pancreatitis, hepatitis, abscesses. But the thing that kills them and family members are the barrianeurysms. They're at risk for having subarachnoid hemorrhages, and they should be screened for the barrianeurysm with some form of brain imaging, either a magnetic resonant angiogram, a CT angiogram, or a straight-up angiogram. If found, they can be clipped or coiled to prevent the subarachnoid hemorrhage. So the difference between autosomal dominant polycystic kidney disease, non-radially oriented cysts that accumulate over time, leading to end-stage renal disease, presenting in adults. They end up on dialysis or get a transplant. Autosomal recessive polycystic kidney disease, anuria and a flank mass on day 1 of birth. Patients usually die. That, cyst and cancer.